My name is Mike Grahn, and I'm the Technology Director of Enteric, which is one of the new healthcare technology cooperatives. Healthcare technology cooperatives are a new player on the English clinical research and development landscape, so I'll say a little bit about them. They are part of the English National Institute of Health Research, which is the research arm of the NHS. And they were formed in order to overcome the problem of getting technologies into the healthcare system in England. Remember that in the UK, healthcare has actually been divided into separate countries for several years. Healthcare, and the problem where healthcare technology cooperatives are looking at is to bring healthcare technologies that actually meet the needs of the healthcare system. And the way in which we do that is by cooperative co-development of technologies. So we started off, in fact, 6 years ago as a bowel function healthcare technology cooperative as a pilot, and that was deemed successful. So since last year, there are now 8 of these HTCs operating in different clinical areas, and we're still operating now, but with a much broader remit in gastroenterology, which is one of the reasons I'm here talking about with groups looking at Crohn's disease, because that now falls within our remit. What we have and what we do is we're a very small core, but we have a network of clinical groups and other partners. Our clinical network covers 24, I think it is now, it does keep increasing, of the gastroenterology units that are active in England. So we cover most of the players, and we have a very wide reach across all types of clinical units, from the very large research-intensive tertiary centres down to much more general hospital, secondary and primary centres. The second set of contacts we have is with industry, with companies, mostly with SMEs, and with academic groups such as yourselves, and with patient representatives and patient groups who also provide a very useful insight. And in identifying a need, and clearly we have a need in Crohn's disease for much, much better disease monitoring, management and control, which potentially the technologies we've heard about today could actually help to address. And once we have a need, we can take players, we can actually disseminate, we can put them together with people who have knowledge at all stages of the procedure and facilitate the development of the technology. And we could give some examples of where we've managed to get technologies from a clinician who had developed an innovation, such as a better operative technique, into a stage where we had co-developed with industry, say, instruments that would facilitate that technique. So rather than having one clinician who's an expert able to do this technique, it could be done by any surgeon easily, and then that instrument is now commercially available, and we achieved that within 2.5 years, which compared to the drug development pipeline is pretty speedy. So we're based in Whitechapel, but our coverage is national and across England. And why am I here? I'm here because I believe that at the next stage of development of this project, of what can be done with VIGOR now, is that maybe we can help, and maybe we will have advantages to ourselves of getting involved in helping, and there are advantages to the project participants. Because it's quite clear from the discussion that the project has reached a stage where several things need to happen. One is that the technology at the moment has been adapted and used by specialist centres and by people who are very au fait with the technology. Clearly, we now have to look to see what needs to be done to make the data interface, the data marking, the data analysis available to clinicians in a wide variety of real-life settings. And one way in which we can help is by using our network of clinicians and actually allowing them to evaluate aspects of the technology as it's being developed, provide feedback, and make sure that what is developed fits in with the broadest possible type of clinical settings and clinical pathways that are out there within the healthcare system. We can also potentially help with trials. By having a large network of groups who are all willing to put in a small amount of time, as long as the data management and the regulatory systems are done centrally, we can get fairly large numbers through a trial by having a small number of patients in a large number of centres. So, for example, we've been trialling a percutaneous neurostimulation for incontinence where we have managed to get groups of patients in control and placebo arms of over 150 within 18 months. That in a functional GI trial is good going. And the third area in which we can help is, I think, and these are just ideas for discussion, but coming out from the discussion today, it's quite clear that you're seeing slightly different results when you analyze your preoperative, your prospective group of MRI images, and then compare them with your with the group of MRI images that you've actually collected through the project. And this just shows that when you're dealing with these computative techniques, you're very dependent on the data input that you're getting, and you need to make sure that that's going to be representative of the data that's out there in the real world. And so one thing we can do and possibly help with is in obtaining MRI data from a wide variety of clinical settings, different machines, different clinical teams, different ways of setting it up. A lot of these things will never actually be documented fully, and you might not find out what the source of variation is, but if we can provide a set of data sets that is much more representative than coming from, say, 2, 3, or 4 centres, I'm not sure how many you used, then maybe that also will be of use to your project in developing the technology further. And that's really all I have to say. Thank you.